Welcome to Blue Briefing, our video look at an important paper published in the Blue Journal. Today we highlight Assessing the Generalizability of the National Lung Screening Trial, Comparison of Stage 1 Patients by Dr. Nicole Tanner and colleagues. Lung cancer remains the leading cancer killer in both men and women in the United States. In a seminal study published in 2011, the National Screening Trial, or NLST, showed a 7% reduction in overall mortality by screening an at-risk population with low-dose chest CT compared to chest X-ray. The people screened in the trial were asymptomatic between the ages of 55 and 74, had cigarette smoking history of at least 30 years, and were considered to be in good enough shape to be operative candidates. The current study in the Blue Journal attempts to determine whether the findings of NLST are generalizable to the U.S. population at risk for lung cancer. Since over 8 million Americans meet screening criteria, CT screening could save many lives if it has the same benefit found in NLST. However, the Medicare-eligible population in the U.S. has important differences from the NLST group. The Medicare age population accounted for only 25% of participants in the trial. In fact, though the average age of lung cancer diagnosis is 70 years old, only 9% of NLST patients were over 70. We also know that older patients in NLST did worse, with lower 5-year overall survival in the subgroup of patients over 65 years old compared to those younger than 65. Furthermore, NLST participants were seen at tertiary care centers with expertise in cancer care. They were often treated at high-volume centers with dedicated thoracic surgeons. Mortality for surgery at these centers was 1%, which is below the 3 to 5% national average at the time. So Tanner and colleagues compared data from two databases to the NLST outcomes to better characterize risks and benefits of screening and treating early-stage lung cancer in elderly patients. From NLST, there were 831 patients with stage 1 lung cancer. 424 were between the ages of 65 and 74, and 379 received treatment with surgery alone. The SEER-Medicare data came from two sources, the SEER program of cancer registries and the Medicare claims covered for healthcare services received from time of Medicare eligibility until death. From these cohorts, patients greater than 65 diagnosed with stage 1A and 1B non-small cell lung cancer from 1998 to 2010 were studied. You can see that there were over 37,000 patients with stage 1 lung cancer from the SEER-Medicare databases, with over 15,000 between the ages of 65 and 74, and of those patients with treatment information available, 9,476 received surgery alone. Almost 3,900 of those who underwent surgery had a Charlson Comorbidity Index, or CCI, of 0 to 1, the type of patient who would have been eligible in NLST. There were another more than 2,500 patients undergoing surgery with more comorbidities with a CCI of 2 or more, so they would not have been eligible for NLST. This figure compares survival over 5 years in patients who received surgery. The first two graphs show the NLST group and the SEER-Medicare database patients between 65 and 74 who would have been NLST eligible. You can see these two cohorts had similar 30, 60, and 90-day surgical survival, though 5-year survival was lower in the SEER-eligible cohort. The third graph shows a group from the database with more comorbidities, the SEER-NLST ineligible group. They had significantly worse 30, 60, 90-day, and 5-year survival than the other two cohorts. The study authors then looked at survival over 5 years in patients who received radiotherapy compared to those who had surgery. Both patients from NLST and from the SEER cohort who received radiation had poorer 5-year survival, 26 and 25% respectively, than those who had surgery, 74 and 60% respectively. Though significant, this result should be interpreted with caution. We don't know if the SEER-Medicare patients in the radiation group received curative dosing, and many patients likely did not receive stereotactic ablative radiotherapy, which may confer better survival in patients who have comorbidities. In conclusion, this study found that surgery was beneficial in early-stage lung cancer in a large national cohort of elderly patients, suggesting that the results of NLST are generalizable to an older population. It also adds further context to lung cancer screening by suggesting that screening patients with more than one comorbidity and those who would not be eligible for surgical resection may not be of value. Please read the full study in the American Journal of Respiratory and Critical Care Medicine. I'm Nitin Seam for the Blue Briefing.